Hello everyone, welcome back to this week's EKG. This week we have a 75-year-old male who is a smoker. The house reeks of smoke when you get in there, and he tells you that he's got a history of a heart attack, high blood pressure, high cholesterol, some reflux, and today he's having chest pain. That's why he called you. And he says it started when he was moving things around his house. He feels a little bit better now, but it's still there. Feels not quite like his last heart attack, but he knows something's not right. So you move ahead and get your set of vital signs. He's got a heart rate of 83, blood pressure looks okay at 125/69, oxygen level is good, blood sugar is good, and then we move on to get our 12 lead. Now when you get your 12 lead, you're keeping in mind that this guy, he's got a history of a heart attack, so we know he's got some coronary artery disease already. And then we start to add up his risk factors with his story. This is exertional chest pain. He's got high cholesterol, high blood pressure. He's a smoker and previous cardiac history. So he's got a lot of risk factors that are making us very concerned about what we're going to find on this 12 lead. And here's what you get. I'll give you a second to take a look at it. And then let's go through it together. So we'll start with our rate like we always do. Rate of 80 is what the computer says. Let's see what lines up with the QRS on the red line here. We have a good red line there. 300, 150, 100, 75, somewhere between 75 and 100. I'll agree with the rate of 80. I think the computer's right. Next, we move on to assess our rhythm. So our two questions here, is it regular and is there a P wave before every QRS? To my general glance here, it looks like it is regular. And then the question about P waves. Do we see a P wave before every QRS? The best place to see our P waves is going to be lead 2. There's a little bit of artifact here that makes it challenging, but the P waves do march out all across this 12 lead here. I'll call this sinus rhythm. So we're happy there. Next, we move on to assess our axis. We look at leads 1 and AVF. In lead 1, the majority of the QRS vector, although it's kind of small, I would say is up there. And then AVF, it looks like the majority, although it's subtle, is down. Maybe since it's not as pronounced, a little less important here. But we do have left axis deviation with our left thumb in the air, and the right thumb for AVF is down, so we have left axis. We'll check our intervals. QRS 84, we have a narrow QRS because it's less than 120. Our QTC 433, that's less than 450. So we have a normal QT interval. The important thing about this 12 lead is our ST segments. So let's do the same way every time. 2-3 AVF. There's maybe an inverted T wave there, but I don't see any ST elevations or depressions. Remember AVL, that should catch your attention, right? If there's a negatively deflected T wave there, pay close attention to your inferior leads. That's not normal, but I don't see any ST elevations or depressions. Moving forward to our septal leads, you may have some subtle ST elevation there above the baseline. And then what I see here is kind of a biphasic T wave. See how that T wave dips down and then comes back up? That'll be important in a second. And then we have just these inverted T waves with maybe not quite ST depression in V4 and V5 as well. So our T waves have caught our attention, and I would call them biphasic there in leads V2 and V3 with some T wave inversion in leads V4 and V5, but no ST elevation changes that I see. So not quite as STEMI, but some concerning changes, and these concerning changes actually have a name and they mean something. So this is why we're talking about this one. I want you to clue into those T waves in V2 and V3 when you're looking at EKGs, because this is something called Wellen's warning. And there's two types of this. One is the biphasic T wave, like we just looked at, where it goes down and then up, kind of like a backwards check mark. Or you can have deeply inverted T waves in leads V2 and V3. The T wave changes can extend all the way through V6, and then this is very important in the setting of chest pain, and sometimes the chest pain may have resolved, but they manifest themselves sometimes when the chest is hurting, and then now the pain has gone away. Much like this patient that we're talking about, he was experiencing most of his symptoms when he was moving furniture. So he meets the criteria for Wellen's warning. Well, what does that mean? Well, Wellen's warning is a warning sign that there's some critical stenosis in the left anterior descending artery. Well, if you remember, the left anterior descending artery is the main artery that feeds the left side of the heart. That's the one where if there's a blockage, they call that the widowmaker. And so if you can catch this before it's actually totally occluded, that is a very good catch. And these are things to watch for, because that means there's an impending anterior wall MI in 75% of these cases. So this guy needs to go to the hospital. He needs to go probably get a stent placed in that or some sort of surgery to get it fixed. And these changes can come and go based on whether or not he's having pain. So it's important, your 12 lead is going to be important for that hospital staff to see as well. But what you want to watch for is this biphasic T wave. You really just need to look in leads V2 and V3. Sometimes the changes exist and can extend over to that lateral side as well, but it's really V2 and V3 that you're watching for. So here's another look at our 12 lead here. I'd call this a sinus rhythm with ST changes in V2 and V3 concerning for Wellen's warning. And that's all we have for you today. Thank you for joining, and we'll see you next time.